We'll move to the next speaker. Our next speaker is Professor Sano. He is the Director of Chief of Gastrointestinal Center at the Institute of Minimally Invasive Endoscopic Care at Sano Hospital, Kobe, Japan. Dr. Sano is going to talk in the next 20 minutes about the polyp detection, characterization, and management using advanced optical imaging. Dr. Sano, welcome.
Thank you for your introduction. Before starting my presentation, it's a really great honor to be here, and so I pay appreciation for the Professor Almadi and the Chairman and the Southern Gastroenterology Society. Thank you very much. So my task to talk today is polyp detection and characterization in management. As you know, in Asian regions, of course in Saudi Arabia, I think colorectal cancer incidence is increasing. And so polypectomy or intervention for the colonoscopy for the chronic region to strongly prevent colorectal cancer. So the identification is very important. So the content, how to identify the polyps and how classify detected polyps, and I show some cases. As you know, recent 10 years, so many novel techniques are arising to detect the polyps. And this is a summarize. So many pancreas endoscopy definitely increase the normal detection rate. And so CAP assisted is also, and SGA is also. And recently, NBI SGA scan has some possibility to improve the normal detection rate. But at that time, so there is no strong evidence to use such novel techniques for the screening. This is a recent meta-analysis of the mean number of the normal detection rate using a narrowband imaging system. Unfortunately, this meta-analysis did not show any improvement for the adenoma detection rate. In our study also, we have two studies regarding NBI detection, but this is still controversial. But so 4 years ago, so narrowband imaging system was improved because the CCD chip was changed to more brighter, and so the light is much more stronger. So as you see, this is the first generation NBI. The center of the lumen, so still dark, but next generation NBI highlights, as you see, the very bright imaging. So how do you think, whether this brighter imaging so truly highlights, truly improve adenoma detection rate? So last year, two papers has been published in Asian regions. One paper is from Hong Kong. One paper, so this paper is using next generation NBI in 190 cities. 190 cities American, Hong Kong, or European doctors use. And this paper showing significantly improve the adenoma polyp detection rate. And the other paper is our paper published last year, so using 290 cities. So it's used in Saudi Arabia. And this study includes more than 450 patients and randomized into two groups, withdraw using a white light, withdrawing with narrowband imaging, brighter narrowband imaging. Interestingly, in this multi-center randomized control trial showed higher detectability in brighter NBI in a selected region, even not only selected region, but also adenoma detection rate was improved. So we think the brighter imaging, brighter new generation NBI. I think as a company also released some kind of blue laser imaging system or other thing. Anyway, this brighter image enhanced endoscopy may be useful for the screening colonoscopy in the near future. And then how to do with PARPs. And characterization is very important because we have lots of identification of the polyps, and we have to manage something. And we are very busy, and we have lots of patients. So selection and characterization is very important for the simpler colonoscopy or saving time or saving resources. So this is a 3D architecture on the normal conic walls. This is normal column is a single straight gland, and so each gland has one crypt, one pit on the surface. And this is features of 3D features of microvessels. Very thin, less than 10 micron in diameter, capillary demarcate around each crypt. And total feature is like a honeycomb pattern, as you see. And this is an NBI, narrowband imaging system. But the capillary is very thin, so you cannot identify the capillary. But sometimes, so you can see the flow of the red blood cells at the precisely. But transform to neoplasia, the capillary changed to much more thicker. So you can identify the brownish microvessel as you see. This is adenoma. So it is a very easy way to select which region is our target. So this is a tiny adenoma, maybe 2 or 3 millimeter diameter. And this is a chromandoscopy, and this is the pit. You can see that on the NBI findings, you can see the pits in capillary. And this is a CD31 immunostaining in the hyperplastic polyps. So on the NBI findings, you can see the surface vessels, surface capillary, as you see this one. But this one is a hyperplastic polyp, so the vessel is very small and thin. So you cannot see. But transform to neoplasia, so you can see. And 2004, maybe 12 years ago, I used a prototype NBI, and we discussed the sequences, some sequences using NBI findings, benign to malignant. And then 2009, I proposed Sano classification using a magnified and NBI endoscopy. Maybe this is the first report. And we conducted some validation study using a microscation. And so this is a prospective study, non-neoplastic versus neoplastic. If the lesion showing brownish vessels, mostly this is a neoplasia. If lack of the brownish vessels on the surface, it is a non-neoplastic. So accuracy, sensitivity, specificity is more than 90%. It's very good data. And also we tried to perform use microscation for the estimation of this depth of invasion, and this is also effective. But I think how is a magnified endoscopy in the Western, or I know Saudi Arabian country also, the use of magnified endoscopy is still low. I think so. There is a barrier for the standardization using our magnifying classification. So I think so in Japan, if we perform the image enhanced endoscopy with magnification, we can receive the reimbursement from the government. But the other country, still, it's not impossible. And I think a low prevalence of use of magnifying endoscopy in Western country or some outside of Japan. So I think a simpler classification is required for the worldwide. So 2008 we got together among UK doctors, American doctors, France, and Australian doctors. And we once or twice per year get together, and we establish one universal international classification, so-called NICE, using narrowband imaging. As you see, this is a very famous world unified, well validated. I think the most well validated classification in the world. So please use this classification, Saudi Arabia also. This classification is very simple. Type 1 is related to hyperplastic or neoplastic, or sometimes the sessile part. And type 3 is related to deep submucosal invasion. So recommend a surgical treatment. The other one is all nice too. So the endoscopically, so the type 1 is you cannot see the bezels on the surface, and the color is whitey. The type 3 bezels, brownish bezel, is sometimes showing irregularity on a dot-like, and amorphous area can be seen. But the other is type 3. And an endoscopic target is a nice 2 lesions. And we published 2 key papers in the gastroenterology 3 years ago, and so this is estimation of depth of invasion and GI endoscopy 2 years ago. And this is a very good data using a nice classification and estimation of depth of invasion also. So if the region showing a nice 1, so we do not reject. But the larger region, we reject, it's okay. And nice 2 regions, definitely we try to remove. Pulpectomy or EMR or ESD. And in the future, so if the region less than 5 million size, we could reject and discard. And type 3 means the invasive cancer, so it's definitely recommend the surgical treatment. I'll show you some cases. This is you identify the 3 lesions on the surface. And this is a white light view. Change to NBI, so you can see the brownish regions here. The other is a whitey, and you can see the black dot on the surface. And a brownish bezel can be seen. So this is adenoma. This is a hyperplastic. So you can try to remove here, this one. And as you see, this is a lesions, adenoma. So you can see the bezels on the surface like this. This is the bezels. So on the NBI findings, you can see the brownish bezel on the surface. But this is a hyperplastic polyp type B lesions. There is no thicker bezels on the surface histologically. So the lesion on the NBI findings are pale and whitey, and we cannot see any bezels on the surface. How do you think this one? This is a conventional findings and white light. This is sessile lesions. But change to NBI, you can see the some depression on the surface. This is depression. And close to the lesions, how do you think this area? You can see the very thick bezel on the surface, and this area you cannot see the bezels on the surface, lack of the bezels on the surface. And very thick vessel can be seen. And how so do you think about the surface pattern? It's a very amorphous. So this is classified as a nice 3. Nice 3 means a deep invasive cancer. Very small region, 8 million size. This is chromendoscopy. This is crystal diet staining, showing so very irregular pit pattern. So anyway, this is a deep invasive cancer. So surgical treatment is required. But this region is very small, so I try to EMR, and then so I recommend the surgical additional treatment. But there is no lymphatic metastasis, fortunately. So anyway, very simple process. And how about so nice classification? Is goes work well or not? So this is our my hospital data, retrospective data. So nice 1 lesion is usually non-neoplastic, and a nice 2 is usually adenoma, and 2 nice 3 lesion identified during my hospital, and these 2 invasive these 2 nice 3 lesion is definitely invasive cancer. First lesion is here. This lesion is very small, only 4 million size, but showing a nice 3. So we recommend a surgical treatment. This is embedded to some cause deeply, and a lymphatic canal invasion positive. And the other lesion is also very tiny, 6 million size, but in so NBI findings. So this area, so you cannot see vessels. So this is a nice 3 lesions. So very tiny, only 6. So EMR, so done, but the lesion embed to some cause deeply, and surgical stone positive. So the patient also recommend us additional surgical treatment. Anyway, so this nice classification is works very well in a daily clinic. And in the near future, but in Japan is already common. But in the near future, in the Western and so other outside of Japan country, please use a magnifying endoscopy. So because magnifying endoscopy is now very simple. Switch the button. This is the dual focus function. So endoscopy. Switch the button. You can obtain so high magnification and view very quickly. And if you, this is our prospective studies. If you, we use a magnifying endoscopy, prediction of the characterization for the prediction for the chronic polyps, histology prediction, is confidence level is improved if you use a magnifying endoscopy. Less than 5 million size polyps are 79%. So if you use a magnifying 92, and 6 to 9 polyps, so no magnification, our confidence level is 84. But if you use a magnifying, it's a 94. So confidence level is improved. So this is my final slide. So if you reach the CCAM, you can switch the NBI or so some other brighter image enhancement techniques. So because detection rate is improved. And then you identify the polyps, please use a nice classification. It's very simple. And a nice 1 is follow-up, and nice 2 your target. Nice 3 is so additional. Yeah, I recommend a nice, if the lesion nice 3, you recommend, so you apply the real chromendoscopy. This is the Japanese way, but in Western country, I think recommend the surgery. Very simple. So, but anyway, such nice 3 lesion is less than 5%. More than 25% lesion you can diagnose very quickly if you use image enhanced endoscopy such as NBI or other thing. Anyway, in my conclusion, so optical digital image enhanced endoscopy has come of age in Asian regions, I think. And a nice classification certainly works diagnostic field of early colorectal lesions, and the simpler optical electronic zoom function is worldwide available, and it improves the high confidence rate. Thank you for your attention.